Welcome to SARC Talk. SARC is a nonprofit cancer research organization that develops and manages clinical research trials in pediatric and adult sarcomas. SARC Talk is a podcast to discuss activities of SARC, interview sarcoma research leaders, and review scientific initiatives in the sarcoma field.
Welcome to SARC Talk, episode number 24. My name is Scott Okuno, a medical oncologist at Mayo Clinic and Chief Medical Officer of SARC. At SARC Talk, we interview interesting people who are connected to sarcoma, where we can all share and spread the knowledge about sarcoma. Our guest today for the new year is Dr. Breelyn Wilky, Associate Professor of the Department of Medicine at the Anschutz Medical Campus, Aurora, Colorado, where she is a director of the Sarcoma Medical Oncology Department. She's also the Deputy Associate Director of Clinical Research Chair and Investigator-Initiated Trials at her institution. Dr. Wilky did graduate her undergrad at Bates College in Lewiston, Maine, and she did her medical school training at the University of, I think it's, where did you do it there?
Well, so they changed the name, so it doesn't really exist anymore, but it's University of Medicine and Dentistry of New Jersey, Robert Wood Johnson Med School.
Yeah, because that is correct. And the dentistry kind of fooled me there, but it must have been something that was quite unique. But from there, she did do her training at Johns Hopkins. I think she stayed on and was a chief as well. And then she did her did her medical oncology fellowship there as well. So she spent a lot of time in the East Coast, which is great. After her fellowship, she did go down to Sylvester Comprehensive Cancer Center at the University of Miami, and then was at position there. And then over the last several years, she then transitioned to the West Coast, kind of, and went and is now at the University of Colorado. Dr. Wilky has served on many different boards. She's an active member of major committees and organizations. She's had multiple grants and publications in the sarcoma space here. She's an invited speaker to many different meetings on sarcoma, and it's a great opportunity to have Dr. Wilky here with us today on SARC Talk. So welcome, Breelyn.
Thanks, Scott. It's a pleasure to be here and really appreciate the opportunity. I'm looking forward to it.
Yeah, well, thank you. And thank you for willing to share a little bit about yourself. But, for all of us, we just like to get to know tell our audience how you got interested in sarcoma, because as you know, it's a rare tumor space, but hey, all of us are living this. But how did you get involved with sarcoma?
Yeah, so I was a baby fellow. I was assigned to consults my very first July as an oncology fellow at Hopkins, and I'll never forget. Like one of my first patients that I consulted on was this young woman, 35 or so, with splenic angiosarcoma. And Katie Thornton, who you might know well, was the queen of sarcoma at Hopkins at that time, and I remember reaching out to her and being like, oh my gosh, what do we do for this lady? And I distinctly remember sitting down and kind of going through the literature. And, this was 2010. So we didn't even have Votrient approved yet or Pazopanib approved. So we really were what I think of now as still in the chemo ages. And so we put together a regimen, and it was incredible because she responded and suddenly she could eat again, and we got her out of the hospital. And, only a couple months later, she was in my continuity clinic and she wound up progressing, and we never really could get her back. She died pretty quickly after that. And so I remember thinking, because I hadn't really decided what I wanted to do yet, but gosh, this was a group of tumors that was really the black box. Like, no, everybody was scared of them. My other mentors and faculty at Hopkins were like, yeah, you got to go talk to Katie. Nobody wanted to really take anything like that on. And so I just had this thought that no matter what I did, whether it was patient care or clinical research, whatever I might figure out, it seemed like it would matter. And I thought, well, my chances of making a difference in this field seem to be a lot more than coming up with like a new magic idea for breast cancer, at the time. So, and I think that still holds true. Like we work together really hard to make advances, and we're seeing results. And to me, it's just the most rewarding thing when you're in a cancer that has sort of been shunned by the rest of the oncology community to a degree.
Yeah, so sarcoma is a black box because, as we know, there are over 100 different sarcomas, so no one wants to touch it per se. Even our colleagues who've been around a long time just don't want to deal with it. But it's interesting, you didn't come to Hopkins wanting to be a sarcoma doctor, but early on you had this niche that you said, hey, this is something that you'll be interested in. To that point, following up then is at Hopkins and in your training, was there a path that said, "Hey, I want to do research"? You highlighted that part where you can go anything or clinical, and how did you make that path distinction, or how has that changed over the course of time? Because I know you do both at this time.
Right. So at least 3 or 4 times in my career, I've sworn I've never set foot in a lab again. And in med school, I remember doing some awful rabbit research about osteoarthritis and sort of trying to check the box, to make myself more competitive as I was going into residency, and I always felt like basic research was so far removed from our patients. And, going into residency and even fellowship, I was like, you know what, I like the clinical trial idea. It seems like it's something where we could actually make a difference, because that line between the research and the clinical trials, the phase ones, is so short. Like, you can actually see new discoveries turned around and actually get them into a patient fairly quickly, compared to other areas of medicine. So I was sort of convinced about the clinical trial piece my first year of fellowship, and my plan was to work with Katie and do clinical research and projects and such. And then she announced, right as I was asking her to be my mentor at the end of my first year, that she was going to the FDA. So it was sort of like, oh gosh, well, now what do I do? And it turned out that one of our peds hemonc guys, David Loeb at Hopkins, had a laboratory, and he did it all. He was a clinical clinician, he was a trialist, and he had a lab focused on Ewing sarcoma research. And I met with him, loved the guy. And the project he had picked out for me was super translational. There was a brand new drug that was getting developed by one of the breast cancer researchers at Hopkins. And I had the opportunity to actually test it in sarcoma cell lines, sarcoma mouse models. And to me, it was like, all right, well, I can see how this work might impact patients in a relatively short period of time. And at least I'm studying the disease I'm passionate about with a whole new drug and mechanism and that sort of thing. So I wound up joining his lab again against all my proclamations, and spent 3 years in the lab, did this research, came out, went to my first attending job, and I was like, all right, I've done the lab stuff. I can talk the talk, but I'm going to collaborate with basic researchers. At Miami, I'm like, I want to see my sarcoma patients. I want to run trials. And then I got into immunotherapy and realized, well, gosh, we need a lab in order to understand and to figure out how immunotherapy is working or not working. And then once again, I had to shift, and now I have a lab, for the third time, where I was like, I guess it's meant to be. At some point, you just kind of got to follow the science and follow what you're passionate about.
So that's true. We'll come back to how you got, back there, but it is interesting that again, from all of our career paths and people that might be listening, they're saying like, "Hey, I had this grand vision from the very get-go. I want to pursue it." It never happens that way. It's usually these things that happen. And I would say Katie went to the FDA not because of you or despite you. That was something she was going to do anyway.
Yeah, I hope
Yeah,
not.
exactly. And then David, as you know, is a consummate did everything, and there's very few of those people that can really do that. And then, so then you said, hey, I'm coming out there. Let's look for a job. Somehow you got to Sylvester. So maybe you can share with the group, how did you get to Sylvester and kind of what were you thinking when you got there? You kind of said you wanted to be a collaborator, a translator, a connector. I assume that's how you went there thinking, right?
Right. So coming out of fellowship, yeah, I wanted to see a lot of sarcoma patients, and I wanted to do clinical trials. And I had been in the lab for most of my time during fellowship, and my last year, my senior year of fellowship, if you will, I had hooked up with Christian Meyer, who's also well known in our community, and had sort of seen patients with him and done some clinical projects, some phase one work. So, I was looking at jobs, and I was down to, ironically, University of Colorado. I was looking at University of Miami and then MD Anderson, and also looking at Hopkins to stay. And the thing with Miami that struck me, John Trent had just gone out there a year and a half probably before I was coming on board, and obviously the guys, the MD Anderson, 12 years, an incredible clinician, one of the world leaders in GIST, and I had the opportunity to be the one junior person under him, compared to some of these other roles where it was more crowded, more established. And again, Miami was one of those places where the potential is through the roof, right? And it's a huge population. You see pathology and cases there you're not going to see anywhere else because of so much influx from Latin America and some of the other, even South America. Like, we would get patients from all over the place coming in. And under John's mentorship. And so I think it was, in retrospect, absolutely the right decision. And I learned so much in those 5 years being there. Not only about the diseases and getting to run clinical trials, and having opportunities to be mentored by incredible clinical researchers and laboratory researchers too. But yeah, I decided there's always been a part of me that loves to grow programs or to be a part of something that's moving and developing. And Sylvester definitely was at a really transformational time for the cancer center as well as the sarcoma program there. And now I think he's up to like 4 or 5 people in that program. So it's exploded. It really has.
Absolutely. So we tell people you have to get enough at bats to understand sarcoma because it's so the presentations, the responses, just the nuances and experience, it just takes time. You can't beat that. So it takes 5 to 7 years. However, at Sylvester, you somehow caught the immunology bug. So tell us how you got the immunologically bug, because that really now changed your career for your next phase two or phase three, as you would say.
Good. So I'll tell you, all epiphanies come from patients. I'm a firm believer in that. And I think I'd been in attending there for about a year, and this kid who 22 years old, just graduated from college, walked into my clinic, and he had a new diagnosis of metastatic alveolar soft part sarcoma. And, as you know, this is a disease where, again, this is 2013 now. There was really one clinical trial going on, and that was the Sutent Cediranib study at the NCI under Alice Chen and those guys. And, I'm sitting there with his family, and they're like, "What do you mean that there's nothing, like chemo doesn't work for this disease?" And kind of going through the statistics at that time, and it's just horrible. And this family looked at me and they're like, "You have to do something. Like, you have to change this. We will start a foundation. We're going to raise research funds, like whatever you need, but make it happen." And this is where sort of the series of coincidences come in. So I have this kid that I'm like, okay, well, I guess this is my job. Like, this is my career now, is I have to figure out how to cure this kid. And lo and behold, there was a peds hemonc at Miami, named John Goldberg, who had done his fellowship at the Farber and had studied a GCSF vaccine for ASPS. Ironic, like, this is where the coincidences come in. And he'd shown that even though patients didn't respond to like this immune boosting vaccine, they were creating antibodies to angiogenic factors. So it's like this connection between the immune system and angiogenesis. And at the same time, Merck was putting out their calls for investigator-sponsored research. Granted, sarcoma was nowhere near on the priority list for that, but between all of us, we put together this trial of Pembro, which was the Merck PD-1 inhibitor, plus axitinib, which was this pan-VEGF inhibitor, a vascular angiogenesis inhibitor. And we were like, all right, well, we're going to do this for sarcomas because a lot of sarcomas are hypoxic and TKIs seem to help, and let's just do this. And I never would have thought I would have ever gotten through the door, but somehow, some way, Merck bought into it and wound up. Here I am running my first IIT, and it's a Merck study with Axi Pembro for patients with sarcomas, including ASPS. And then, even though ASPS is super rare, we wound up putting 12 patients from all over the world who traveled to Miami to do this study. And it wound up coming out that that ASPS was responsive to immunotherapy. Obviously, we weren't the only people to see this, but this was sort of the first trial that demonstrated that more conclusively. And then, just at the same time, I was doing studies in angiosarcomas, phase 1 trials of checkpoint inhibitors, and I'm seeing these people who had failed dozens of chemotherapies or other treatments, and we're seeing disease melt away. And it only takes like one patient to kind of give you that bug where you're like, okay, this works for some patients. Like, how do we make it work for everyone? And sort of as the whole culmination of all of that and that opportunity, I decided I needed an immunologist and I needed a team, and I wanted to do this for the next stage of my career.
Awesome. It's interesting. All of us still reference your paper, even though it's all sarcomas, but there's a good cohort of alveolar sarcoma with the combo, and all of us are still trying to figure out, is the combo better? We don't know. We did get the other study that was done by Chen, through NCI, is showing that Nivo, atezolizumab does work. So you set the stage. So now, here we are. You said, now I'm back in my next stage of my career. I want to develop an immunology aspect. You then made a decision to pivot and go to Colorado. And maybe you can share with the group, what was your ultimate plans of going over to Colorado, and how are you building your program out there at Colorado?
Right. So obviously Miami was an incredible experience, and we'd pretty much wrapped that trial. And I had a couple ideas for some new studies, and I'd gotten a grant to do correlative work on the biopsy samples and the blood samples from the patients on Pembro. And so I was sort of at this point where I needed to be in the lab, and I needed to start a lab to do this work that we proposed. And we had proposed modeling in mice models and things like that as well. Um, and I had amazing collaborators. I had a great team in Miami. But when I had started talking, of course, with Victor Villalobos, who was running the program out here, and they really wanted to take the next step and build up the lab research aspect of the sarcoma program here in Colorado. And they had just recruited two key people. One was Terry Fry, who is one of the developers of the original CD19 CAR Ts for pediatric leukemia, coming out of the NCI. So he had just joined Colorado. And then the other person was Eduardo Davila, who is a 20-year cancer immunotherapist, PhD, works on TIL therapy, so tumor infiltrating lymphocytes, and engineering those to become better cancer fighters. And so those two people had just been recruited to Colorado at the same time I was starting to look at this possibility. And Victor had built a beautiful clinical program. It was busy. He was getting all the big name trials out here. Denver is absolutely beautiful. And so I was looking at an opportunity to come out, really be able to delve into my research and figure out how to run a lab with good mentorship on the immunology side. And that's not even to mention the entire department of immunology out here that's incredibly talented. National Jewish does some cutting edge immunology work as well. Like, this is a long history out here. So it was a very, very difficult decision. These things are never easy, and to pick up and start over is not for the faint of heart. But I did it, and it's also been a challenge. It's been incredibly challenging for a variety of reasons, which I'm sure we'll get into. But I'm super happy out here doing what I'm doing, which is now the three-headed monster approach, where I'm seeing patients, doing trials, and then also trying to run a lab.
Just like basic science, you go where the expertise is, and this is a good opportunity for you to go there. You have a good clinical collaborator in Victor, and then when you get there, Victor decides something different, right?
Well, it wasn't right when I got here. So look, like I got out of here end of 2018, beginning of 2019, and COVID hit March of 2020. And COVID was a disaster, as we all know, and incredibly disruptive to everyone for every reason. And Victor decided somewhere over that summer that he was ready for a change too, and his passion has always been, sort of big picture development and drug development and trials, and having the resources to sort of create the next generations of studies. And he found an opportunity in pharma, and that he couldn't refuse either. And so he wound up going to take that role, which certainly wasn't expected. But again, life is short, and I think that's what we all learned from COVID, particularly while we're all bunkered down, like not doing anything, is that sometimes you gotta make big decisions for what really matters, and happiness is important.
Yeah, absolutely. So here you are, the three-headed monster, doing everything again, but you said, hey, let's build out the program again. Can you share with our audience here, how have you built out the program, and where do you see the program going in Colorado now?
Right. So Victor had started this program. He came out here again about the same time I did, so 2013, 2014. And Anthony Elias is one of our faculty as well, who's been seeing sarcomas for a very, very long time, along with breast cancer, which is his passion, and he's been very involved. And so Victor came on board and really started to take things over. And you saw this sort of exponential growth over the last several years in terms of volume, trials. Um, we have a very strong multidisciplinary infrastructure here. So there is a very strong Hopkins presence led by Rich Schulich, who's our cancer center director and pancreatic cancer surgeon who's been the chair of surgery here also for quite some time. So they developed this multidisciplinary clinic model. And so this is basically a one-stop shop for patients with newly diagnosed sarcomas, as well as other disease types, where they come in and they meet with our PAs, our intake PAs. They get presented at tumor board with the entire team. So the surgeons, the rad oncs, the pathologists, the med oncs, and so on. And then in the afternoon, we actually see patients together. So I'll see a newly diagnosed high grade UPS or something of the extremity with my orthopedic oncologist. So as that's matured, the volume has gotten so big because our catchment area out here is huge. Like we have Utah, we have MD Anderson, we have like Seattle, and then Wash U. But in terms of like major cancer center, Arizona, Mayo Clinic, of course. But like if you look at the catchment area, there's a lot of really really big states that all kind of funnel into Denver for a lot of the clinical research and the cancer care. And sarcomas, like we're really the only sarcoma center for a very large stretch of the country. So basically, what I've been trying to focus on since I've been here is getting trials that really are important, and a variety of trials, not just immunotherapy, but making sure that we're representing the needs of our patients. So big phase 3 studies. We have a very strong phase 1 program, and so what we've seen is just sarcoma patients from everywhere from Montana to New Mexico to Nevada and Kansas, Nebraska. Like all of these states are sort of funneling in, and they'll travel and come to our program to participate in these studies. So obviously I needed help, and the next step was really to get help, and especially with Victor leaving. So a couple years ago, we recruited Alessandra Miledu, who is incredibly talented medical oncologist, originally from Italy, and then did sarcoma work at University Hospitals London for several years before coming out to join us here. And she's just been an absolute rock star and a pleasure to work with. And then we have a new orthopedic oncologist that we brought in who is just a superstar, Steve Thorpe from UC Davis originally, who's just been really innovative and a lot of enthusiasm and new ideas and revamping sort of the ortho side of things. So we're growing, and I think it's just a really exciting time for us here too.
Well, the nice thing is that you're right. You guys are the center out there, even though you're kind of in Aurora. I mean, in that the Denver area there, and you have a great catchment area, and you're building out the team, which is exciting. To that point, we see everything, okay? And, there's been the era that we've used cytotoxic therapies. There's an era that we started using targeted therapies. We're now in the era of immunotherapy, and there might be others that we say. And for our group, can you share, where do you see us right now in sarcoma and immunotherapy? Are we still in the infancy stage? Are we at the adolescent stage? Are we ready to family wise? Where do you see us in the space of immunology, and what are more things that we need to know about immunology in sarcoma?
No, great questions. Yes, I think for sure we're still in infancy. We are light years behind. Like infancy seems a little bit kind. The problem is that we are so unique in our field because we deal with so many different diseases, right? And yes, there's heterogeneity in other cancers. I'm actually writing the paper for the AXI Pembro correlative studies right now, and so I've been like digging around looking at some of these correlates, and I watched this ASCO presentation from Brian Rainey, who's one of the renal cell guys, and he literally presented correlates on 800 patients that got axi-pembro versus sunitinib. I'm like, 800 patients got RNA-seq. I'm like, are you freaking kidding me? Because like we struggle to get correlates done on 20 to 30 patient studies. I mean, yes, there's some bigger ones that have come out, but SARC 028, which is sort of like the flagship study for immunotherapy, had 40 patients, right, on the soft tissue side, and it expanded and whatnot. But and then you start to do the math, and you're like, well, I got 2 responders, or I got 4 responders. Oh, and this person didn't have a biopsy. So our ability to really make these cross tumor, cross patient comparisons and try to make any effort at understanding the immune microenvironment is an incredible hurdle, right? But we have to do it, because if we just keep, like, we don't have the liberty to just keep slapping different drugs and all of these new targets without any sort of understanding, because with only a few shots on goal, you have to get really, really lucky. And sometimes we do, and we get super lucky and we get all excited. We're like, this is the next therapy. And you know what I'm talking about. Like, even in chemo, like, we see these promising signals in small studies, only to take them to phase 3s. And then we realize we're beaten by the heterogeneity, right? And by, just the power of the numbers. So that's part of why my role, like, I'm not a big phase 3 person. Like, I'm not going to be the sort of person that likely pushes these giant phase 3 studies, or relatively giant for sarcomas. I love being in that phase 1, phase 2 space where you're trying to learn from every single patient, and you're trying to literally pull every single piece of data and every correlate and every nuance of that patient's history to generate the ideas, right? And that's really where we are, I think, with immunology. It's exciting because you'll see patients with these incredible responses, and there's a few subtypes where we're pretty confident that we got a good shot at getting responses to checkpoint inhibitors, at least. But we haven't really scratched the surface of some of the cooler stuff that's coming, like CAR T cells and engineered TILs and MKs. I mean, there's so many things that we haven't really begun to get into, and so yes, I'd say neonate stage, Scott.
Okay, neonate. So
Yeah,
we're past the embryo stage, but we're
yeah,
out into the neo part.
yeah.
So people that are listening, and you think immunology has all been taken care of in other tumor groups, we have so much opportunity. So if you're interested, let us know, because we still need more and more work to be done. And in fact, those who do have the opportunity, I hope it's still up there. Dr. Wilkie did have a point counterpoint during our SARC meeting at ASCO, and Breelyn, you maybe want to share kind of that so that people understand how that all came about.
So I think it's a philosophical discussion that we had. Like, you guys put together this incredible debate session at SARC, and the question was whether tertiary lymphoid structures, which are basically these little mini lymph nodes or clumps of immune cells that can exist within tumors, were evidence of a pre-established, good quality immune response that would predict that those patients were going to respond to checkpoint inhibitors. And it sounds great, and there's a ton of data, which I won't get into just for the sake of time. But the debate was whether or not we were ready to pin all our hopes on this one biomarker, right? And I think that's where it gets scary, is because, again, that's assuming that we are ready, with the knowledge that we've gained, and the correlative studies that have been done, and the technology that we've actually have at our disposal, and the small numbers of patients that we've analyzed, to pin our hopes on that. And it's not a problem. It's not a problem to explore that in trials, in my opinion. The problem is to proclaim it as that we're done looking, right? So my only hesitancy with, and the subject of my debate, was to not be so focused on that one particular avenue that we gave up on trying to get immunotherapy to work for all the other ones, right? So because TLSs are in somewhere about 20% of sarcomas, depending on the subtypes. And the responses were a little bit better when the trial was done that selected for those, but it wasn't perfect, and it's not the entire story. And again, this work we've been doing with the axi-pembro correlates, that's going to hopefully come out here if I can ever get the paper done. It shows that there's so much more complexity, and every single patient has like this unique balance of all of these factors in the immune system that are all playing a role, and we need to. my goal one day is that we'll be able to take a patient and we'll profile them and we'll look at the immune cells that are in that microenvironment, and we'll be able to understand what the driving forces are, whether it's macrophages or T regulatory cells or tertiary lymphoid structures and tons of antigens, and we're good to go. But we haven't really figured that out yet. And, it's just, I get scared because the problem is then, you go and there's cooperative groups, or there's bigger like pharma companies that have actually come to me and been like, well, yeah, we're going to run a study for TLS positive sarcomas. And I'm like, okay, well, that's great. But, have why, like, which ones are you going to, like, why not just do UPS where we have like sort of the signal without spending the expense and the time to try to look for these things? And they're like, no, it's the biomarker. And it's like, well, wait a minute. So my only hesitancy is, that it's easy to jump on the bandwagon, but we can steer ourselves in the wrong direction for quite some time if we're wrong.
Yeah. To that point, you are very nice. You're very articulate, and your approach to oncology, approach to sarcoma is rationally based. And I don't know where you get it from or how you got it, or you can thank somebody else before you how you got it. But it's not saying it's bad. It's just like, let's not hang our hat just on that. And I think that's the balance that we all need, because there'll be a lot of bright, shiny stars out there that we'll go chasing. And in sarcoma, we don't have 8,000 patients to put on a trial, or even 800 like Rini does. But, we only have 30, 40, and it'll take 5 years to do it. So you get the idea. So, people are listening here and they're going to say, hey, I might be a young investigator. I might be interested in sarcoma. What advice would you have to the younger self, a younger Breelyn, saying, hey, I'm coming through sarcoma. I am now on service. I'm seeing my first sarcoma patient, first year fellow. What would you say to that individual, to your future self, if you look back?
So um, I remember my first ASCO, and I think I had gone. It was with David Loeb and Christian, like my first ASCO or whatnot. I had gone to the SARC meeting. Like I remember very clearly my first SARC meeting that I was sitting in, and I'm looking around, and like, Christian's like, that's Bob Mackey, or that's Bob Benjamin, or that's this person, that person. I remember sitting there going, oh my gosh, like I'm sitting in the same room with these people. Um, and I think the thing I love more than anything about our community is just how approachable, how supportive, and collegial people really are. And I think I would tell anyone who's interested in sarcoma that, strike up that conversation, like go to the poster sessions at those meetings. And, if somebody's presenting a poster and you recognize their name and you're like, oh my gosh, like this is this person, like just talk, because that's the coincidences are what makes everything happen. And I think that's so true in medicine. And there's been like these conversations that I never would have thought were significant, and it turns out to be very, very pivotal, and they can really drive research, they can drive career decisions, they can drive all of these things. So, don't be afraid to get out there and actually talk with people in the field. And I think, we've done a couple of things well to that point. So one example is sort of this Women in Sarcoma group that Gina D'Amato put together several years ago now. And really, it's just an email list of women in sarcoma, and it's every like very, very senior people who've been doing this for a long time. It's fellows, residents, junior science folks, like postdocs in the lab, and it's just everybody is sort of on this link. And if you have a question about a patient, like this happens at least 2 or 3 times a week, where you literally can email the whole group and be like, hey, I don't know what to do, or I'm in this weird situation, what would you guys do? And it's just no questions asked. Like people respond if they have time, people who don't respond if they can't. But it's been incredibly productive. And then you actually like have something to talk with people about, right? So, that's one example. I think we've also done a great job through ASCO and CTOS with some of the mentorship programs. And I just, I applaud all of you guys who have been responsible for making these things happen. But some of the Sunrise mentorship sessions where, people are sitting down, I absolutely love doing that. And I think, it makes you reflect not only on your own decisions and what you might have done differently, but really just getting to connect with young people and encouraging them to not give up, even though it's a rare disease and it seems like there's no funding and there's no grants and pharma companies don't want to do trials, like all these rumors and things that are not really true. You just kind of got to know where to look, and you need a good partner and sponsor.
Absolutely. So if people are listening and is, oh my gosh, that's Breelyn Wilky, you can still talk to her too.
It's
So just
terrifying.
remember that. Okay,
Oh
terrified.
God.
But to that point, and I think to that point, SARC, his whole, the story is always like we're not approachable. It's a closed group. The answer is no. Sarcoma, SARC is a very open, collaborative group. Reach out to any of us. We try our best to communicate because the best ideas are the ones that we all have. I mean, whether it comes from someone who's been here like a Bob Mackey or Bob Benjamin, in those days, or Lee Hellman. I'm just saying names, but the reality is that these are people we all looked up to. But you go talk to them, they're just, as you said, just normal people. So, but we're all normal people. So
Some of us
that's
more
the
normal
part.
than others, but
There you go.
that's fine. There's a
But
spectrum.
but the unique thing is in the part that I think people need to understand if you're listening, and part of other groups in there is sarcoma oncologists, whether it's a researcher, surgeon, etc. In the sarcoma space, we are different than other medical oncologists. Now, Breelyn, how would you describe that? I mean, because we're weird, because we're like nerdy, we get into the details, and no one wants to do that black box. But how would you describe a sarcoma medical oncologist?
We're resilient. I mean, we got it. So it's so funny because we used to have, I get into these arguments with, or I used to before pancreatic cancer got FOLFIRINOX and BRCA and like all these other things that would actually make pancreas better now. But we used to argue about like which disease was more challenging. There's the sarcoma group or the pancreas cancer groups, and like there's all this rivalry. But I mean, if you come to my clinic, like, or anybody in our clinics, like you're going to see stuff that will just blow your mind. I mean, and it's the whole range. And it's not just the diseases, or it's a scan, an ASPS scan where literally like there's no normal lungs left, but yet somebody just went and climbed a 14er last weekend. I mean, it challenges so many different aspects of oncology because it is so different. It's head to toe. You get like the entire range of complications. We use the entire armamentarium of drugs, right? Like we are experts in some of the most cytotoxic chemotherapy regimens that are given. I still admit people to the hospital, which nobody does anymore otherwise, and we don't bat an eye at 5 days of undetectable neutrophils. I mean, there's a different tolerance for stress and anxiety, I think, in sarcoma docs, just because we have to. But we are resilient. We're resourceful. We are not. I'm not one who's going to look up NCCN and go, oh gosh, my patient's not an NCCN. I guess we're done. Like, and there are like, I've literally had this conversation sometimes with people that don't treat this disease, and they're like, well, I did first line and I did second line in NCCN, and now the patient's going to go to hospice, and I'm like, well, the guidelines aren't really sufficient for these diseases sometimes, and let's talk about trials. Let's see what else we can come up with. I mean, your patient's in good shape, so. I think that we have to use our whole toolbox, and then sometimes we need to reach beyond the toolbox.
We recorded it. I'm going to keep track of that and kind of say, yeah, that's what a sarcoma oncologist is. And I told Rich Radale this too, and I said, I hardly ever look at the sarcoma NCCN guidelines because you live it and do it, and we kind of periodically have to check to make sure like where we are and where our therapies for reimbursement purposes. But we're right, we're very creative in those that do it every single day. The guidelines help people that don't do it every day, but to your point, part of your career has been very collaborative. I can just tell by what you do. You like the laboratory. You've done IITs at Sylvester. You're leading that group also at CU there. You've done industry trials as well. Which is a huge part. Um, where do you want to focus the next 5 years on? Because are we going to see the fourth turn on a Dr. Wilkie,
Oh
or is
God.
this? Where do we see this? You're in there now. You're building a program. You think, yes, you can spend some time really developing more aspect of immunology, but where do you got? Is that where your focus is going to be in the next 5 years?
Yeah, I think so. We I can't, like we were talking about, I came out here really with the focus on like checkpoint inhibitor combinations, right? So the TKI story, I'm really interested in chemo immunotherapy combinations. We've done a trial looking at that and doing a bunch of lab work, really trying to tease out the mechanism of doxorubicin and how that impacts tumor immune responses. And so that's sort of been like the first five. I've been here for 6 years, so like this period of time minus COVID and the drama, like that's really been what we sunk our teeth into. But in partnership with Dr. Davila, who is really my right hand person in the lab, he's got this incredible technology that he's been working on for 15 years, where essentially you take TILs or tumor infiltrating lymphocytes out of a tumor, and he has a construct that lowers the threshold for the T cell to fire. So what that means is a normally crappy antigen or a very self-looking tumor cell, something that would never normally trigger a T cell to fire, he's rigged it so the threshold to fire is much, much lower. And we are actually in the process of preparing a first in human, first in class IND for this, to run it out here, and I get to run the study. And we convinced him that sarcoma was the lowest hanging fruit that he could possibly include in this trial. So we're doing head and neck, molecularly driven lung, and then soft tissue sarcomas, selected subtypes that actually have TILs that we can get out. But as part of this, again, I sort of did this pivot because, I've never done anything with cell therapy apart from taking part in the Adaptimmune and the MAGE-4 synovial trials. CARs have been, they're mostly pediatric tumors that have targets for CAR Ts. So I really have no clue about adopted, or at least I didn't until I came out here, about TIL therapy and like what that means and how you run cellular therapies and what those unique considerations are. But I actually put my first R01 in this year, which was a pivot award to change again from checkpoint inhibitors and sarcoma to now, okay, like what are some more universal mechanisms of TILs, and like what are we actually doing, like how does that antigen versus TIL interaction really matter? And we're going to look at some of the correlates coming out of that trial. So it is a bit of a shift. So I fully expect my next 5 years to be enveloped in that technology and really trying to follow that out. And then hopefully wrapping up again some of the things that we've done here. But it's comes down to what I think is one of your other questions, which is really like, like in the immune therapy space, like how do we move the needle forward as a community? And one of the things that's so vital that we figure out some way to do is how to blend our data and to how to pool our resources and become comfortable with working together. Because I don't think one lab and one person is going to be able to sort this out. And when we look at patients who are treated with immunotherapies, and you look at the TILs and you look at the immune microenvironment, there's so much noise and there's so much difference that 30 patients on a study is all over the place. And that's assuming that you try to limit your subtypes, which most people don't. And so I'm hoping that in the next 5 years, the leaders in this field, we can all come together and really try to push for creative ways to share our data and to maybe take advantage of AI and the robots and big data and all these algorithms and really, really smart young people who know how to code, which we never learned that either. If I could go back in time, I'd tell my young sarcoma person, learn how to code and like go to R camp and like do all the informatics stuff that you can now, because like it didn't exist. But anyway, that was a roundabout answer to your question.
Well, no, it's very direct because, one thing that we're starting to see in all of our careers is that, yes, you want to come here with this idea. The people around you have a good idea in TILs. If you talk to somebody a year or two ago, where we are with cellular therapy, T cell receptor, and that space, as you know, is going to build out and that part. But these all are kind of using the same immune and different ways of activating it. So it's all aligning. So when we talk again in 5 years on our next podcast, we'll hear a little bit more of where you've developed the TILs as we move forward. Fingers crossed. The other part too, and I don't know how much you're still actively involved with this, was getting the word out, doing the social media aspect. And I know that does take a lot of time and effort. And I know that there's ups and downs in Twitter. I'm not even sure if TikTok's going to be around here, pretty soon. Not that we do that. And then also the Facebook aspect. And can you kind of share how that has been helpful for us in our careers as we build out these networks as we move forward?
I will tell you that one of the smartest things I did as a junior person was to actually do the social media thing on a professional basis. So what I did, because I realized, and again, nothing against John, and I've told him this, many times too. So I'm not like trashing Miami at all or that experience. But I mean, I was a brand new baby. Nobody had ever heard of me, and John was the legend. And so you'd get these people coming into Miami, and they're coming to see John. Like they didn't want to see me. Like what have I done? What do I know? And so what I did about a year and a half in was I decided I was going to start a blog, and because that was like a way to get my voice, my messages, my philosophies out, and to share research and other things, because I realized like nowadays patients are not asking their primary docs for a referral for like who they should go see. Like they're going online and they'll find the foundation websites and they'll look at like, oh, okay, here are my sarcoma centers, or here are the doctors that have given these talks or videos online. Or they might, if they Google me, like they'll find this blog. And so I watched as that and Twitter at the time, just being out there, I could have sort of my own identity. And it sort of helped me get past some of the seniority, because I could say what I wanted to. And then patients would be like, hey, I read your blog. And hey, how's your dog? Because I had a picture of my dog on it, and it created like a connection that was sort of outside the traditional, um, you know, climb to greatness, if you will, among academic rankings and experience and publications and presentations and things like that. So, and I think patients use this, and I've told every pharma company that consults with me, like if you want to reach patients or if you want your drug and your information to get out there, don't just market to the docs, like especially for sarcomas. Like going into the community and talking about a very elusive sarcoma drug is not going to do any good. But if you go to, because they're literally going to see one in like 20 years, but if you go to the internet and you work with the foundations and the advocacy groups and you say, hey, like let's go to where the source is, those patients then are the most powerful tools for distributing the knowledge, the research, the trial opportunities, all of those things. And again, I get more referrals from foundations. Like I have to credit the EHE Foundation for the rest of eternity for like massive amounts of EHE referrals, just because again we partnered very early on, and we just it's just a different way that things happen nowadays than I think they used to 20 years ago before all of this happened.
Correct. And I think that's the highlight we just wanted to share with our audience too, is that you don't want to take a guy who is, I'm not saying how much older I am than you, I don't know, but we didn't grow up with this, okay? And my person who mentored me, we didn't have any social anything. So they came looking for my mentor too, and says, "Why am I seeing you?" The same concept. But I do think a structured sharing and directing the narrative, because you have total control what you put out there and how you retreat, makes a huge thing. Blogs, yes and no now anymore. It's Substack, those type of things that you do. But I do think there's a good space as we start to build out the community, and we'll end in our conversation with the engagement of the patient advocacy groups, because that's how you and I kind of got to know each other with the National Myelosarcoma Foundation, and Denise Robinson and the Jane and the team over at EHE when we were doing this as well. There's Factor, which is also the OGS. There's all these great, and DTRF. These are great organizations, and they help share the word and spread the word too. And they have a very active presence as well with good content and good community. So as we end, kind of thoughts on younger, and I say anybody that the engagement of those groups and social media. Any other thoughts on that, Breelyn?
Totally could not agree with you more. And, junior investigators, those are the people to talk to too, right? So yeah, I remember John got me to go to one of the Life Raft Group Just Awareness Days, right? Like he had me give Just 101, and I got to talk to patients. I got to meet all of the folks there, and they knew who I was because I gave this one talk at Patient Awareness Day. And those things really, really matter. And again, if you're a junior person and you're trying to build a program, you've just come to a place that maybe hasn't been as established of a program, and you want to get the awareness days and you want to get the clinical trials, like that's how they're incredible partners, the foundations and the groups, to be able to extend your reach really where it matters, and that's out into those patient communities. So I completely agree. And, as we move forward, there's so much more push to integrate patient advocacy groups and foundations into clinical trial design, into grant reviews, like funding decisions. I mean, like, you partner with these folks, and that's a huge thing. It really strengthens your application, and it shows that you are in touch with what the community actually needs, and you're not just doing something esoteric that won't have buy-in from the people that it actually matters for, right? Like, you can't accrue to a trial if on Facebook the patients are talking about, like, oh, this trial is horrible because you're randomizing to placebo and that's not helpful for patients. You know what I mean? So it's like there's things we can learn from the patient experience that are really, really valuable as we write trials or we write grants and design research.
100%. Have to be on board early. They're critical to success, accrual, participation, conduct, preparing patients to get to these centers. As you know, teams will start funneling patients into you. However, there's only one Breelyn Wilky. You can't be involved with all these organizations. And I know you've consciously made sure that you're available for the organizations that you do. All of us do work in those spaces, but then you transition, let other people do that work. And we do appreciate that time and effort that, we all love to do. If we had unlimited time, we'd be at every single organization. It's just hard.
Exactly. Yeah, and it's time you need to get new voices too, right? Like, it's just like the saying is somebody shouldn't be a chair of a department for longer than X number of years. You need, like, the new vision, the new leadership. And I think that's true for advocacy groups too. You want new ideas. You want to shuffle the guard from time to time, so that we don't get stuck in our ways and in the trenches, if you will. It's how we grow.
100%. We don't want to be stale. So as we get to the end here, I think we do a lot of good service for the sarcoma community. We hope we do as clinicians, and what we do is, where do you see our opportunities in the sarcoma community moving forward as we end here tonight? Where do you see our opportunities?
There's lots of opportunities, lots of places to grow and get creative. And I think there's different ways that we could think about that. Part of it, I do think, is learning to or figuring out ways to work together a bit better, in terms of what I was talking about, like data sharing and things like that. We have to somehow beat the numbers game, and honestly, a lot of it is not on the docs and the researchers not being willing to. A lot of it's the legal hassles and the hurdles to sharing tissue or sharing data. Our institutions put up a lot of roadblocks sometimes, to protect intellectual properties and so on, or international collaborations, which we all do not infrequently in sarcoma, because it is an international group of researchers. That can be incredibly challenging, right? So I would love to see, some of these initiatives that have started to kick off that are challenging those dogmas, right? Challenging the legal requirements, challenging the idea that you have to have, um, you know, one informed consent that then has to be blessed by every IRB for every center that's participating in one of these data gathering initiatives, right? And we're seeing people start to figure it out and create new ways to do this. The patient derived, or like the patient donated research, such as Count Me In, the angiosarcoma project, the work that the Broad's done is a way that proves that concept. Like, you don't have to be restrained by some of these old rules. And I think as those things grow, with good leadership, I think that's going to be a tremendously powerful way to beat the numbers moving forward.
So I hear the common theme: better ways to collaborate, break down the barriers as we move forward. And we'll probably solve that in 2025. So I think we're pretty good there,
Good.
right?
Well, hey, I'll take it.
Yeah.
Then we got to figure out what to do with all of it, and
Yeah, exactly.
you know, how we develop our hypotheses. Like, how do we use that data and that information to design the next trials, and then how do we get buy-in from others, right? So you can come up with the ideas, but we got to execute too.
Absolutely. Well, Breland, this has been great. It's always great to hear kind of how your story is, and I think hopefully people that are listening can also feel comforted that it's not a direct path. It starts and stops and fits in that, But I think we have a very positive outlook in sarcoma going forward. All the success for you and your team over in Colorado, and we look forward to more productive collaborations as we go forward. Any final comments for our listeners today, Breelyn?
No, I want to thank you for the time and listening to me ramble on about the things I'm passionate about. And I would say to the audience, we are like, it's just a fantastic area of clinical care. We say we have the best patients, the most wonderful patients ever, because everybody is just so unique. And I love my job. I really, really do. And I think you need to find what you're passionate about. You need to find what actually excites you and inspires you to go to work every day. And it's okay if that changes over time and you need to revamp things or go in a new direction. But I think it's an exciting time in medicine, it's an exciting time in cancer research, and I think with all of us working together, we'll get sarcoma up there and really see even more progress in the next decade or so.
Yeah. Well, we're looking forward to that, and what a great way to start 2025. So thank you, Dr. Wilky. And for those that are listening, please send us comments because we do listen to them and look forward to that. We do have future topics every month coming out, but if you have ideas, please send them to us, and we look forward to a great 2025. Thank you, Dr. Wilky.
Thank you for listening. Be sure to subscribe so you never miss an episode of SARC Talk. To find out more about SARC, please visit our website at sarctrials.org. To suggest a topic or for questions, please email us at sarctalk@sarctrials.org. Together, we can find a cure for all forms of sarcoma.